Dr. Henry, I know you said that the information would be up on the website, but can you explain a little bit about how the criteria for declaring an outbreak in care homes is changing, what it's going to be? And we're hearing that this change may have been made in late December or early January. Can you tell us sort of when it goes into effect or when it went into effect and exactly what the new criteria are, please?
So, as you know, we had guidance that was posted up on our on the BC CDC website, and these are public health guidance that MHOs use on a case-by-case basis to make a determination, and they're based on the information, and I've talked about this a few times, that we have from our regular respiratory infection outbreak guidelines in long-term care homes. And so they were quite prescriptive about the things that must be done if there was evidence of transmission within a facility. So that included a single positive case in a resident or more than one case in a staff person where there was transmission within the facility or potential exposures. So that was an important, very sensitive definition that served us well with the serious illness that we were seeing with multiple different strains of the virus, and particularly before we had vaccinations and before we had booster doses. So we are now seeing it is qualitatively very different in long-term care homes with Omicron. And because there's so much spreading in the community, we see rates, background rates in long-term care homes as well. So it is much more around a changing situation, whether there's severe illness, so more symptomatic illness. We're no longer doing asymptomatic testing, screening of everybody, looking at who's getting the vaccination levels, whether it's more serious, whether other respiratory viruses are calling it. So it has always been at the judgment of the MHO doing the investigation of each of the outbreaks, but declaring an outbreak is a little more nuanced now based on what we're seeing in a highly vaccinated population, both workers, visitors, and residents in particular. And the measures that we're putting in place in an outbreak are not as extreme as the ones that we had in place. And I talked about, overall measures, but especially outbreak measures. So still ensuring that a vaccinated, protected visitor can come in for every resident, even during an outbreak, so that they get that extra support that they need, for example. And there's a few other things that are part of that as well. And yes, this has been an evolution, as we've, very similar to the hospital data, as we've seen Delta fade away and Omicron causing very mild illness in many cases in both staff and residents.
Binder, did you have a follow-up?
Yeah, I just wanted to ask about the rapid test. It seems like pretty big numbers are coming in now to the province. We know people now are turning to Facebook groups, for instance, to try and find out which pharmacies may have them, and wondering why they don't have access to some of those rapid tests that are now coming in this month. Some people need to know or need to show a positive test for work purposes, for taking sick days, but is there a plan to distribute those rapid tests that are coming in a more, where people can just pick them up at testing sites, because, people want to know whether they have COVID or not?
Yeah, I'll let the minister take that one.
Sure. So we laid out a very detailed plan, been there on December 21st, as to where our priorities were for the use of rapid tests. British Columbia, as you can see by the large numbers coming in to the province, are getting its full share of rapid tests, 13.5% of the national supply, and we're using them in these priority areas. So I think I noted that if you're talking about 10 million rapid tests, that's less than 2 per person, and we're using them in priority in areas such as long-term care, acute care, to support our testing sites where they're there, in schools, in post-secondary, and some work sites, in areas where there's congregate living and others, to ensure that people are safe. And that is, you see in detail today, the way those tests are distributed across the system. So that's what we're doing. As we get more, we may be able to extend that more widely, but those are going to continue to be the priorities. Priorities are going to continue to be our healthcare system, continue to be supporting K-12 education and post-secondary education, continue to be to support childcare, continue to be to support certain workplaces where the risk is highest. And they're, of course, a part of today's announcement around visitors in long-term care. So that utilization, as you can tell by the numbers being distributed to those areas this week, I think it's about 1.3 million. That's a lot of use of rapid tests across those systems of the supply we get. The rapid tests we're going to use. And the only exceptions to that are the ones that we're drawing down more slowly, which are ones that require specialized equipment or a healthcare worker. And so we're going to continue to do that over time. And obviously, as we get more, we'll be able to somewhat widen that. But those are going to continue to be the priority areas. We laid it out in detail what we're doing. And it's not dissimilar to what lots of other jurisdictions are doing as well. But this is our priority, which is to protect the most vulnerable, protect the healthcare system, and to ensure that critical things, such as to support critical services for parents and children, such as K-12 education, childcare, and post-secondary education.
Our next question is from Rob Shaw. Check. Please go ahead.
Could I just get you to walk us through the essential and designated visitor situation again? I guess I find it a little bit confusing. If seniors have essential visitors now, but only 1/3 of them actually have that declared, and the concern is that it's the care home administrators who can decide if a senior's essential visitor is actually an essential visitor. And you said today, during an outbreak under the changes, essential visitors can still go in and visit. Can a designated visitor still go in and visit? And a designated visitor doesn't have to be approved by the care home administrator. Could you just walk through the differences there and what it means for seniors?
That's absolutely what it means. So we have a process in place already, and as we've mentioned, about 1/3 of seniors and residents of long-term care have somebody who needs to be there as part of their care team, helps provide that extra care, and those people have been identified already. What we are moving towards, and what we have moved towards, as I've mentioned since the end of December, is making sure that in addition, every single resident at their choice can designate somebody to be their visitor, and you can have a backup in case somebody's ill or can't come in. So yes, if you have 2 children, one of them can be your essential visitor if they're already designated, and you can have another person come in to be your visitor. And that's what we want across the board. That's what's aligned with what the representative for seniors, the seniors advocate has suggested, whether we think is really important. And they, yes, can come regardless of the transmission rates in the community, regardless of whether there's an outbreak in a facility. They will need to be, because we know that it's still pretty risky, they'll need to be vaccinated themselves, and that's why we're prioritizing long-term care for making sure we can test people with rapid tests as well. So those are at the resident's choice, and every resident is entitled to have their designated visitor who can come at any time, and that's in addition to those people who have already been identified as essential visitors. Does that make it clear?
Rob, did you have a follow-up?
Great, thank you. Yeah, Minister Dix, could I ask you to comment on the Victoria woman who yesterday got a call from nurses at Royal Jubilee Hospital to come and ask her to come feed her 87-year-old mother there her 3 meals because there wasn't enough staff. Apparently, the family had to do that again today as well. Is that acceptable? Do we know if other families are being asked to do this? And what happens if a patient doesn't have family who can come in and feed them?
Well, to the latter question, no one's ever denied, obviously, care or left without being fed. And so that simply doesn't happen and would not happen in those circumstances. What does happen, and I can't comment on the case, just so that everyone understands that regardless of the public comment around the case, we can't comment with the information we have, which are part of the privacy afforded to people in our healthcare system. So we don't comment on the individual cases. What happens, and what happens frequently, and this is before the pandemic and now, is that visitors frequently help with care, either because they want to or because it's the patient who's a relative may ask them to, or because the care staff think that's a good idea, and that frequently happened before and after. So it's not an issue of the individuals being called in to do that, but that it can be a helpful situation for many involved. There's no question that there's staffing challenges. You saw in the numbers we provided in Vancouver Island Health right now, but there's also no question that everyone is going to be fed in that process. But sometimes people get asked to come in and help, especially when they're providing care around. And again, this is not about this case. I'm not commenting about the case, but and that I think happened before the pandemic. It happens now, and it will continue to happen. So the issue isn't that people aren't going to be fed. Of course they're going to be fed. The question is whether staff ask for a variety of reasons for family members to come in and assist, and often that's a very good thing. Sometimes for the family members, sometimes certainly for the patient that happened. But in no circumstances would someone not be fed, and I think that would probably be obvious to everybody. But this is an important question, and I'm very appreciative of the family's concern. And if there's a specific complaint, there's an independent process to review those complaints. I encourage people to take it to those processes as they have complaints about the healthcare system, because that's important. It's also important to know our care staff, and it's been one of the challenges throughout the COVID-19 pandemic in long-term care, as we've just discussed in acute care, is often families and visitors play a very important role in supporting the care and the recovery of people in both acute care and in long-term care and in other health circumstances. So the short answer is everybody gets fed. But this is not unusual that visitors, whether they be essential or otherwise, be asked to contribute to that. And I gather, without commenting on it, but from hearing what's been reported in the news, that's what happened in this case. But those are the circumstances anyway. And obviously we want to make sure that everybody is well treated so that their recovery and the support for whatever brings them to hospital is well supported in our system.
Our next question is for Richard Zussman, Global News.
Dr. Henry, Pfizer is now working through the process of getting its vaccine approved for those under the age of 5, so I think from 6 months to 5 years old. At what point do you expect to see that vaccine available here in British Columbia? And what would your initial thoughts be around people of that age getting the COVID-19 vaccine?
Yeah, so yes, I've been watching that with interest. This was the FDA in the U.S. Suggesting that Pfizer start the process of applying for emergency use authorization, which is slightly different from the process that we have here with Health Canada. And we've talked about this before, that the initial dosing tests on children in that age group indicated a 1/10 dose, so slightly different from the pediatric formulation we have right now. But the immunogenicity studies they did, so that's seeing if they give that dose to that age group of children, if they have a similar antibody response to what we see in adults that we know is protective. So it's what we call a correlative immunity. And what they found was they weren't getting as strong an immune response. And partly this is because our immune system develops over time when we're very young, and sort of the ultimate time frame for a strong immune system is in that sort of 6 to 15 to 20 year age group, which is why we see such great benefits from vaccine in the kids in that age group and in teenagers. So the short answer is they are continuing, and the FDA and others in the U.S. Asked Pfizer to add a third dose to the protocol for that age group. But what they're doing, given the rates of transmission they're seeing and the hospitalization rates in younger children in the U.S., the FDA has said, go ahead and put in the application with the data that you have for the first 2 doses. And then by the time we have the opportunity, as we have seen, it takes months in many cases to review that data, to understand the data and to look at it in detail. They should have results of the third dose part of the study. So it is looking at ways of starting immunization programs for younger children in a high-risk environment where there's a lot of transmission still in many parts of the country, as the continued testing of how many doses is actually needed is ongoing. So that's kind of complex. As far as I know, Health Canada has not yet taken that approach, and we're still waiting for the information from Pfizer and the data on the first 2 doses and the 3rd dose. Having said that, it is important, and we have seen young children being affected by COVID. We've had admissions to hospital in the 0 to 4 age group. We've had 2 young toddlers, 1 toddler, 1 infant, who've died from COVID over the course of our pandemic. And we know that it can cause severe illness in young ones. So it is important that we have a vaccine that can protect, especially those highest risk children in that age group. And we'll be looking to Health Canada to review the safety and effectiveness data as it becomes available here. I don't think it will happen in the short term, but I do expect that as soon as Pfizer gets the more detailed data, they will submit it here and to Health Canada as well.
Richard, did you have a follow-up?
Dr. Henry, I'm receiving a lot of notes from people who are trying to plan trips outside of the country for spring break. And one of the challenges they are facing is around a potential COVID diagnosis. Because of the limited testing capacity here, many of them are not able to get tested. As you are aware, I'm sure, if you have a PCR test confirmed, there are certain rules around travel in terms of getting retested. All of this considered, would BC consider providing documentation for those who tested positive on rapid tests to allow for that travel? And what conversations have you had with your federal counterparts around changing some of these confusing travel protocols that could be prohibitive for people who in BC were never able to get a PCR test?
So this is not unique to people in BC, and yes, there are some. I will say that the publicly funded testing system is not for private personal travel like that. So no, it's not available in our, PCR tests in our publicly funded system needs to be focused on the people for whom it'll make a difference in terms of either their care or going back to work. There are some provisions in places, I know in private clinics, to be able to get a confirmation associated with a rapid test positive at a person's own expense, like other travel clinic services that are provided. It's very hard to, as you know, there's a trajectory of antibodies that are picked up by these tests. So if we're talking out in March, somebody who had an infection now is unlikely to test positive on a PCR test that far out. But those are things that are very challenging things. And yes, the federal government is reviewing, particularly as in the provinces and territories, we've changed our isolation requirements for people who are contacts and for people who test positive, and they're not aligned anymore with some of the border measures. So we have had ongoing discussions about the border measures and what tests are required when and why, and I know they are reviewing those in the next few weeks.
Our next question today is from Lisa Cordasco, Vancouver Sun. Please go ahead.
Thank you. I want to talk about the changes to how you are going to adjust outbreak management, your management approach. In changing when a medical health officer may declare an outbreak, some would say that, outbreak should still be declared because then visitors and residents of care homes know and can judge whether they will continue to go to activities or whether visitors will be continuing to visit. Declaring an outbreak just simply tells the public that there is COVID circulating in a care home. Medical health officers from that point on could use their discretion to say, yes, visits will continue or activities will continue. Is that the approach that you're using? And if not, if leaving it up to declare an outbreak in a care home, how is how are members of the public or, visitors or even residents in care homes to actually know that there is a COVID circulating in their facility?
There's lots of things that are packed into that, and it is a little bit. The MHO is not in every facility every day, and of the 200 and some that are in our province, and it is that community that understands what's going on. And yes, we liaise with each individual facility. The facilities themselves and our teams in the regional health authorities, that include the MHOs, it includes infection control. They are in constant contact with the different facilities about what they're seeing. So the people, what we're seeing now is that, yes, there may be a resident who tests positive for COVID, may have mild symptoms but test positive, and they are individually isolated in their room. We have overall provisions in place so that you only go visit your one person, you wear a mask, you're tested, staff are tested regularly. If they have any symptoms, they wear PPE all the time. So there is measures in place that help reduce the risk of transmission. And there are people who are asymptomatic who have this in our community now, and that includes in long-term care homes. So all of these other things help reduce that risk. And if somebody tests positive, they know, their roommates know and are isolated. If they have roommates, their families are notified, and they aren't able to participate in group activities. So it is a matter of finding that balance of knowing if there's a few cases, but there's not a lot of transmission happening. You can isolate those individuals very effectively now because so many people are vaccinated and because we have these other measures in place. So that's on a home-by-home basis how we're managing right now. And then if there's more transmission that's not, that we're not sure who's passing it to who, it's more severe illness, and we've had that with RSV and we've had it with Delta still causing a couple of infections, then we need to take more additional measures and give more detailed notification to the broader community. But it is trying to find that disruption of people's life and ability to be with their loved ones versus risk right now.
Lisa, did you have a follow-up?
Yes, I can appreciate that care homes would be taking measures to reduce risk, but my question is about the declaration of outbreak. That triggers an actual public warning that COVID is circulating in a care home. People can make their own decisions after that, and including medical health officers to decide, what protocols are going to take place in any care home. My question is, you're abandoning that requirement that people be informed if you don't declare an outbreak. So, and then not declaring an outbreak and giving them all kinds of options. Aren't we going to be all over the place with where an outbreak is and isn't and what's going on and isn't going on? Why not just declare outbreaks and then decide protocols for handling it? Leave that to the discretion of medical health officers.
This is what we do in long-term care homes, have done for many, many years. And it is about finding that balance and that judgment. And if there's not influenza, COVID circulating, we may have cases, we may have individual people, we may have rooms where there are individuals who have COVID. There may be a number of staff who have COVID, who are off and no longer in the facility. Those don't constitute circulation within the facility that puts people at risk right now. So it is finding that balance and that judgment, and we don't need to tell in 300-bed facility that one person has COVID. It's finding that balance right now, given what we're seeing circulating. And it is very much a part of a relationship that we have, and a really good relationship now, where people are taking additional measures on a daily basis to make sure that they're protecting themselves and their loved ones and their fellow workers in long-term care homes.
Our next question is for Lisa Eustace, City News. Please go ahead.
I'm wondering, with all the information that you've laid out today, Dr. Henry, and and talking about, you sound a little bit optimistic that by February 16th, at least some things are going to be lifting. But laying out, how it's affecting hospitalizations and ICU, are we sort of looking at going the way of Denmark and England, that we are really going to see a large lifting of regulations in the weeks or months to come?
I think I made it quite clear that we're still on the ratcheting up the dial versus on and off switches. So there's some things that we know are working and give people the ability to do higher risk activities more safely. Things like the BC vaccine card, things like some of the higher risk settings having capacity limits. So wearing masks in indoor settings, especially some of the higher risk indoor settings. So there are some things that we will need to continue to do for another period of time. I do absolutely think that we'll be able to lift them at some point and we'll have no restrictions. But I do think at some point we're going to get to a place where we can think about having those important life events again in a limited way and gradually increasing that to a place where we can have larger groups of people together for wedding ceremonies and celebrations of life and birthday parties and all those important things that we've been missing this last few months.
Lisa, did you have a follow-up?
I do, and this one's probably more for Minister Dix, but not sure. Regarding the rapid tests and your response, I think Richard asked the question. So you're saying that there's 4.2 million that are around right now, 500,000 can't be used. And so that's, nearly 3 million sitting there. So I guess people are left scratching their heads why there isn't a process by which more people can have access to them when there's that many that seem to be sitting there, when they're just, people really haven't seen them much at schools. I think they're starting to trickle in, or at universities. So is it just that we haven't seen them in broad numbers at those places where people want to access them, and people are really scratching their heads about why they can't be more broadly accessible when there's this many millions sitting there?
But the thing, I'll add to that. There's 600,000 children in K to 12. There's another, how many staff are in K to 12, plus post-secondary institutions. And so, 3 million sounds like a lot, but they're also packaged in packages that they're not 3 million individual packages of tests. And that's, 3 tests for every school child. So it's not a lot when you look at it from that perspective. So, and yes, they are getting into those settings now, and many of them just came in the last couple of days, as you know. But I'll let the Minister talk to details.
So you talk about 3 million tests. We've had tests in the millions come in the last 3 days. And what happens is we come in, we adjust, we process them, and then they go out. And I laid out in detail where 1.2 million are going this week. So what you're seeing, I think, is us taking the tests when they arrive. They're not always consistent on their arrival. And then distributing them to the areas of priority. And those areas of priority, again, are acute care, testing centers, long-term care, assisted living, schools, K-12, schools, post-secondary, child care, workplaces, congregate settings, and others that are priorities and have been designed as priorities by public health and by those who are driving the initiative. So there's none sitting around. We get millions come in. It takes us some days to process them, and then they're going out. And that's what you're going to see. You're going to see a significant increase in that number in the next couple of weeks. So the next time I report, there will be many millions more arrived and many millions more distributed. And so nothing's waiting around, and we're giving priority to those areas where we can have the biggest impact on the pandemic. And those are the areas I've described. And that's what we're doing. We're getting the tests coming in the millions in a given 3-day period, and then they're also going out in the millions, and that will continue to happen. So if you take it at a point of time, when 4 million tests, say, arrive one day, and you say, well, there are 4 million tests, well, those will be going out to those priority areas, and you'll be seeing them around the province. And obviously, we've been doing dramatically more rapid testing in the last few weeks as a result of the tests we have.
We have time for one more question. Our final question today is from Belle Puri, CBC. Please go ahead.
Dr. Henry, by the end of this month, children 5 and up will have had time to get both doses of the vaccine. And many of those in that age group have already been exposed to it or have been mildly sick and recovered from Omicron. So given all of that, when do you think school might return to normal? Masking would be optional, no social distancing, field trips would be allowed, and we need an answer in French as well, please.
Yeah, one doesn't, I'm continually reminded of the travails of speculating. I kind of thought we were in a really good place in December until Omicron hit us. And we still are seeing this virus spreading rapidly around the globe. We still see new things coming up every day, whether it's, the BA.2 in Denmark and the UK and South Africa now too. And we've had some of that here. So there's a whole lot of things that we don't yet know. And some of the more challenging things to implement in schools are the ones that we hope to get rid of first. But it will depend on decreasing circulation rates in our community and our balancing in our healthcare system. So I do think, by the time we get to spring, we're going to be in a very different place, I hope, at least for a period of time. And this is my speculating a little bit. With recognizing my optimism bias. But I do think with the level of immunity that we have, with the level of protection we have through vaccination, with the amount of milder illness in those vaccinated people, that gives a boost to your immunity for a period of time as well, that we're likely to have a gentler spring and hopefully summer. And we'll need to prepare ourselves in all areas for more unknowns come the fall, because it is pretty sure that this virus is going to come back in some form in the fall, and hopefully it'll be in a form that is still, we still have good protection from the booster doses of vaccine that we've had, and that we can manage our healthcare system.
Oui, ce que la Dr. Henry vient de dire, c'est qu'il est possible que notre printemps va mieux qu'aujourd'hui, n'est-ce pas, dans le contexte, et ça va être plus doux qu'actuellement. Mais cela étant, en vivant un moment où on a plus d'un millier, un millier à l'hôpital, un millier 30 à peu près, ou à 40 en ce jour-ci, et un taux de positivité de 19 à 20%, ce qui est important quand même dans le contexte de l'histoire récente de COVID-19, c'est-à-dire que c'était de taille de 3% au commencement du mois de décembre. Donc, nous vivons une période mouvementée difficile. Et je pense que nos enseignants, nos professeurs, nos administrateurs, nos étudiants, nos parents font un travail extraordinaire dans des circonstances. Bien entendu, on veut que ça va mieux au printemps, et ça se peut, surtout pendant l'été, ça se peut, et c'est plus que se peut, c'est à ça qu'on s'attend. L'automne et l'hiver prochain encore présenter des nouvelles difficultés à tout le monde. Donc, je pense qu'il faut maintenant rester stable et calme, et c'est difficile, et le travail effectué par tout le monde dans le système scolaire est extraordinaire, mais difficile. Et on espère que ça va mieux, mais ça ne va pas être la semaine prochaine ou même le mois prochain.
Bill, did you have a follow-up?
Dr. Henry, I think you said 60% of COVID cases in hospitals are among patients admitted for other reasons. So how much is that related to the policy of not keeping COVID patients separate, putting them in rooms with vaccinated people? How much is that a contributing factor? English and French, please.
I'm not sure I understand your question. Are you asking whether there's been transmission in hospital because we've put people with a COVID positive test in a room with somebody who's low risk and COVID negative?
Right. Like, I mean, we're
I'm not
hearing
aware of any transmission.
COVID patients in.
So, what we are seeing is people are being admitted to hospital for surgery. Actually, where we're seeing it most commonly is surgery. People being screened for surgery, people being screened at labor and delivery, people being screened for mental health and substance use admissions, and some of them are testing positive. They are asymptomatic, and precautions are put in place to make sure that while the period of time that they have a positive test, that they aren't able to transmit it to others. But I'm not aware of any transmission from having people in a room together, I guess, unless I'm missing the question. Sorry.
Bill, did you want to clarify your question?
Well, no, I think we've been hearing that COVID positive patients and vaccinated people are in rooms together. So we're just wondering if you've had cases of transmission in those situations. Do any of these people who go to hospital for a non-COVID reason then end up being positive for COVID? Did they get it there?
Yeah, so we have had a number of acute care outbreaks, as you see in our outbreak report, and that's where somebody was unknown to be to have COVID, and it's been transmitted in a acute care setting. But there's been no transmission from a known COVID positive person being placed in a room or ward with other vaccinated, low-risk people, according to the infection control policy that we talked about a couple of weeks ago.